Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Michelle Cooke, founder of Soul Direct Primary Care, about illuminating the path to DPC. Let's get started. Hello, Dr. Dan.
Hey, Faisel. How are you today?
I am doing much better now. And Dr. Cooke, welcome. It's so good to have you.
Thank you so much for having me. I'm super excited.
You know, it was so great to reconnect with you. It's hard to believe that it's been 10 years since we saw each other at the national conference. And we're actually in the week, we just finished with national conference.
I know. How amazing.
One of the goals that Dr. Dan and I had when we started doing all this stuff on social media was to try to inspire more medical students to pursue primary care, of course, family medicine residency training programs, and then also for the residents to pursue careers in just a high quality primary care working environment. Can you share with us your journey into direct primary care and what inspired you to choose this model over the traditional fee-for-service practice setting?
Oh my gosh, how much time do we have? Let's see if I can condense it. I think, with first choosing family medicine, one of my favorite pieces of advice in medical school is don't go where you have the most fun on your rotations, go where you find your tribe. And that was some of the best advice I got. And what that mentor was telling me was that sometimes students, they go to surgery and they see a gallbladder out and they catch a baby in OB and they're just excited by everything. But there's you have to be able to do that thing 1,000 times and still be excited by it. So go where the place where you have where you see yourself, where the doctors think like you, where they have family lives the way that you have, their interests outside of work or what you're interested in. And as much as I thought surgery was so cool and OB was so cool, it wasn't always the lifestyle I wanted to live. I love my surgeons, but I do not think like a surgeon. I'm just not that type. And so I found my tribe in family medicine. What I loved about it is that the diversity of what you can do. You can see babies, you can see the elderly, you can do a lot of women's health. I really love women's health, but I'm not a surgical person. So doing an OB residency that was half surgery just was not going to work for me. And family medicine just seemed to be where it was at. What I loved about family medicine is the core is family. I'm a family person. Being a doctor is important to me, but more importantly is being a wife, being a mom. And this is about being a family-oriented person and supporting other people in their family. So it was such a natural calling. So getting into family medicine was a pretty easy choice after I made that discovery. I worked as a family doctor pretty much exclusively outpatient for up to 10 years. And I was working for a large healthcare system here in Atlanta. It started out like most things, good enough. It's pretty cool. You're growing patients, you're developing those relationships. And then I started to experience, I think a lot of family doctors and doctors in general started to experience, you get that crunch. My institution wanted me to see more and more patients. I didn't have enough time with the patients. I had way too much administrative duties and I was rapidly burning out. And so you just get to that point where you're saying, I really love medicine, or I told myself I still love medicine, but I was like, I don't think this is the way I want to do it. It was really eating at my soul. And I didn't realize how much autonomy that I wanted to have, but when I had no control over how long I could see my patients, that was a real problem. It's one thing if you say, I cannot safely tell somebody or educate somebody or counsel somebody who's suicidal in 15 minutes. I can't counsel somebody and tell them they have cancer in 15 minutes. And when I couldn't have control over my schedule, I was like, this is not okay. In addition to just all the other nonsense that happened, I started to get into leadership, thinking that could help. You take the baton and you're going to change things, right? You're going to make it better for all the doctors. And honestly, that was the beginning of the end. So leadership was hard. I learned a lot of skills. I learned about how to be in the corporate space and, how to circle back on things and, how to, all the stuff that we learned. So I learned a lot of that.
Double click. Let me double click on this.
Exactly.
We could circle back. We could double click, circle back.
All of that, this is an area of opportunity. It's not a problem. I learned all that speak. So, but what I hated about being in leadership is I feel like my organization wanted me to further crack the whip on more doctors. I was doing these performance improvement plans on doctors who were behind on their charting. I know why they're behind, because what we're asked to do is impossible. We know that. We know that primary care doctors need 26 hours a day to get their job done. And so to get mad at them that they're behind is just stupid. So excuse my language, but it was ridiculous. And so it really, again, added to my moral injury that I'm trying to tell these doctors to work faster, work smarter, when we know that there's data that proves that our job is impossible. So leadership was really tough for me because I felt like I was not in alignment with what I went into family medicine for. I felt like I was hurting my colleagues. And then the other thing was it worsened my workload. So I was supposed to be 20% leadership and 80% clinical. I'm like, oh, great, I get to cut back 20%. But nobody took my patients, right? So now it's like 100% clinical with 80% of the time to do it, plus my 20% leadership role. And it was the beginning of the end. All in the background of this, I had learned about direct primary care. I was probably maybe my 5th year when I was into my practice. I went to a Georgia Academy of Family Physicians conference, and the wonderful Julie Gunther and Rob Lambert, who are like OGs in this movement. Yeah, awesome. They gave a talk about direct primary care. And I was like, this is what I'm looking for. This is exactly the type of way I wanted to practice, but I just wasn't brave enough. I was like, I'm a doctor. I'm not a business person. I don't know how to do that. I was just terrified. Like, it made so much sense to me. And it was always like in the back of my mind, like, oh, there's this amazing way you can practice medicine, but I just never felt like I had the guts to do it. So if we fast forward, I'm 10 years into practice. I'm in this leadership role. I'm miserable. Like my time is not my own. I have no autonomy. Yes, I have a little bit of power and leadership, but I'm doing things that are so out of alignment with what I want. And then what happens is in Atlanta, the healthcare system I worked for hit a big financial hurdle and shut down 2 hospitals and multiple primary care clinics in my district. So I'm in a big city. I'm in Atlanta, right? And the area I serve it's underserved for a lot of different reasons. It's a large minority and Black community. And all of a sudden, the hospitals are closing and the clinics are closing. We probably provided the most care to this community, and all of a sudden it's gone. And to me, that was a huge wake-up call because, number one, we weren't closing because of lack of business. We were busier than ever. Patients are beating down our doors. We have long wait times. Our hospitals are full. The problem is with our model of care, right? How do we have so many people trying to access care, but we can't make the business model work? It just didn't make sense. So it was the worst time for me professionally. It was also the best time for me professionally because when that closure happened, I was given a termination notice. They said, Dr. Cooke, you're a great doctor. This is not about your performance, but we're closing this location. We're going over to the other side of town. You can come along with us, but we have to terminate your contract for being at this office. And I was like, you know what? This is my ticket out. It's my ticket out. It came to me because I didn't really want to stay. I wanted to plot my exit. And I was like, and I've learned that we can't continue this way. I'm not going to stay with this organization and continue to do what I think is so wrong about what we're doing. This is now time to start direct primary care. So the stars just kind of started aligning, right? So I get this termination, which was a blessing in disguise, even though it was terrible for my community. Second thing that happened, which I'm super fortunate for, was I hit 10 years in a not-for-profit. So my student loans got forgiven. So now I have a little bit more financial bandwidth. Right. And then the third thing that happened is because I got this termination notice and they were leaving the market, it effectively released me from my non-compete. So I'm like, bam, this is like a triple whammy. If there is no other sign out there, like it is staring me in the face that I have to do something different. So that was my ticket to start direct primary care. So I just started digging in, learning more about the movement. I got mentors. I went to conferences and I just said, if I'm going to stay in medicine, there's no other way I can do it because what I was doing before wasn't working. So that was in November of 2022. I took about 6 months to take a little bit of a break and start my practice. And then in May of 2023, I opened Soul Direct Primary Care, the first direct primary care practice in Southwest Atlanta. It has been quite a journey so far. I've had to learn to wear a business owner's hat, an entrepreneur hat, exercise skills I never thought I would exercise before. But the beauty is I have time with patients. I have autonomy over my time. I can go to my son's soccer practices. I can be home. Like sometimes I work a little later than I should, but it's not because I'm overwhelmed. It's because I have more control of my time. So it's been a phenomenal experience and there's no way I can go back. So I'm still growing the practice. I'm working on some new projects. We're launching some medical weight loss initiatives. But another thing I'm interested in is really going back and saving my colleagues. I want to make sure we bring more people into direct primary care to know that we don't have to be miserable, that we can be the doctors we've always wanted to be, and our patients get better care. So that was the shortest way I can explain my path to direct primary care, but I think it was helpful to understand all that background.
What's interesting, you said you have the only practice in Southwest Atlanta. So you didn't go to Buckhead. You didn't go to a high income area to do this. And so how is it working to do the direct primary care model? Are you feeling like you're still able to serve the community that you want to serve?
I love that question. So there's a couple of different answers to that. Southwest Atlanta is very mixed income. So I'm glad you know the Atlanta landscape. And for those that don't, Buckhead is the ritzy side of town. A lot more wealth is in the Buckhead area. It's not Buckhead, but it's very mixed. So we have very poor people down here, and we have people with a lot of resources. So I got to Atlanta because I came to the illustrious Spelman College, which I'm very proud of, went to Morehouse School of Medicine. They are very well-known, prominent, historically Black colleges and universities, and many of the graduates live right here in this community. They're the doctors or the lawyers or the politicians of our community who have some resources. But even apart from those folks, there's a lot of middle-class folks in this area that have some resources, that have flexible spending accounts and health savings accounts, and they have some resources they can deploy to healthcare. So I say that to say there's mixed income, so the income is here to support the practice. The other way I like to answer that question is, honestly, if you ask me, if you are living in the United States, when it comes to healthcare, you are underserved. And that is particularly true for Black people and especially Black women. So here in Atlanta, it does not matter your socioeconomic status. If you are a Black woman, you're 3 times more likely to die in childbirth, no matter what your SES is. So I feel like everybody in this community, even if they have $1 million, $3 million, they are underserved because they cannot access a healthcare system that will listen to them, that will acknowledge them, that will give them their needs, and that will do it at a transparent price. So I feel like, yes, you have to be careful about your price point, but almost no matter what my price point, I am serving the underserved.
That's a beautiful answer. And, that in the 6 months that you spend before opening your practice, one of my favorite things about the direct primary care community, you mentioned Dr. Julie Gunther, who's been a guest on the podcast, and she's a friend and reminds me I should probably reach out to her to see how she's doing. And we've had other direct primary care doctors on, but I love how open and how much information is shared from one physician to another doctor. I mean, like blueprints are actually created that, hey, this is what you can do to get things started. Can you share a little bit about that, the aspect of just, because that's one of the issues that we come across with, especially with the students. For those of us who pursue medical school and family medicine, primary care, we're not the business. We weren't the people who were interested in talking about, let me just take care of patients. We talk about the patient first. We always lean in with the relationship. We'll sacrifice our own time. We'll sacrifice our sanity. I know we have a 15-minute appointment, but this is something that's going to take longer. And the knocking on the door, disregard that because I have my patient. So, and I loved hearing that from you. But I'd love for you to kind of share about the community and how the community help, because you're not a business person.
Not initially. And I'm learning to stop saying that, right? I'm not a business person, but it really is all about mindset. And I agree with you. I think like you and I, we graduated from medical school and residency around the same time. And I think we came out in the generation of you finish, you get employed, and that's how you're going to practice medicine. And I think that's a fairly modern phenomenon. If we go back, not to age you, Dr. Dan, but if we go back to when you probably finished medical school and residency, a lot of doctors were hanging their own shingles. It's like they started practicing their community. They stay there for 30, 40 years. They're a community doctor, and they had to understand the business side. So I just think we were groomed very differently than just the generation prior to us. And I think that was a huge mistake. Just like with adulting, right? You can't just ignore that there's bills to pay. If you're practicing in a profession, you have to understand there's a business aspect to it, and we can't defer that responsibility. We have to get some understanding of how to run a business. And the reason behind that, number one, is that we need to have autonomy in the way that we practice. And I think the best way to do that is private practice ownership. The other thing is, I feel like when we're employed and when we are working in an insurance-based model, we feel like we can't think about the finances, but our patients are heavily affected by the finances. I tell a story all the time about how I had a lady that I convinced, she was 65 and just refused to get her pap smear. Dr. Cooke, I'm not getting my pap smear, just refuse. And I was like, I can't tell you that you don't have cervical cancer if we can't get your pap smear. So we finally do her pap smear. Thank gosh it comes back negative. But what I didn't know was something about her Medicare plan did not cover HPV testing, and she got hit with a $400 bill. Sent my poor patient to collections, right? So what I couldn't have with her is a conversation about financial informed consent. I couldn't say, this test is going to cost you this much. Would you like to opt into it or not? Now I can say in my practice, I mean, oftentimes in direct primary care, I don't use insurance very much for my services. But I can tell that patient, look, we can try to run your pap smear through insurance, but if you want to do it cash base, it's $88. And they can make a decision. And I was never giving my patients informed financial consent when I talk to them in the fee-for-service model. So I would recommend this service, and it's happened to all of us. They go to the pharmacy and it's $1 million, or they go to get a CT scan done and, you're told them it's so important. I think you have a PE. This could be life or death. And they get there and they're told it's $3,000. And they're like, oh my gosh, my doctor thinks I'm going to die. I do not have the money for this. How do I make this work? So us deferring the knowledge about business and dollars is wrong. And it hurts us and it hurts our patients. And so I just don't think that we have a responsibility to know the finances of medicine and know how to work that in favor of our patients. So for me, I feel like direct primary care is now the most ethical model of care that I've ever practiced. There are some people I say that come to my website and look at my prices and say, oh, that's too expensive, but they've made an informed decision, right? You can't go to urgent care and look on the wall and see how much it's going to cost you. You go, you get these services, and then a month later you get a bill for $500 and you can't dispute it now because you've already gotten the care. So I just think as doctors, we have to get over that idea that we're not business people, that we can't understand it. I try to talk with my colleagues and say mindset. We have to change our mindset. We are physicians. If we can master the Krebs cycle and place central lines, and like I say, there are less intelligent people who have run successful businesses. The guy that cuts my grass runs a business. He has a QuickBooks account. He can send me invoices, and he didn't have to go to med school to do that. So I think we put so much weight on this, oh my gosh, business is so big and we can't understand it. We can figure it out. And in some ways, business is a lot more forgiving than medicine, right? If you make a mistake, you can fix it. You can refund people. You can, you can't always do that in the medical route, but business is a lot more forgiving. So I think as doctors, we have to understand that this is possible. There are people with a lot less training who figured out and can do it successfully, and we can too. And the longer we don't do it, we're actually harming our patients.
The complicated part about the business of medicine generally has to do with the insurance companies and the different fees charged based on people's insurance plans, where honestly your business model is much closer to your landscaper's business model, right?
Exactly.
Because
exactly.
You're charging a fee for a monthly fee, and there aren't really any surprise gotcha charges. And if you're getting ready to do something else, you're going to tell them this is what it's going to cost you. Do you want to do that? Makes it very difficult when you don't have the information in front of you. And I think part of it has to do with getting resident training, in that the residents don't have access to the cost information, and in many ways they're sheltered from it, either by the disproportionate share payments or the 340B pricing, so that the people coming through residency programs often the residents aren't having to deal with the full brunt of the cost of medication. Their patients are getting medications at a lower price. Now they're out in practice and they write a prescription for, I think it was the first time I ever wrote a prescription for a GLP-1 drug. And at that time I was working in a rural area, and the woman walked over to the pharmacy and walked back into my office, and I heard her talking to somebody at the front desk using some rather choice words.
Right.
Has he lost his mind? What does he think he's doing here? That was an interesting, you got to be willing to have that conversation.
Exactly. And I think once we get into having those conversations, we can be much better advocates for our patients, because it's not just residents, but like you said, physicians who are practicing, we have no clue, because it depends on so many factors that are so complicated and not even worth figuring out, right? So if you have Blue Cross Blue Shield, but if you have a gold program versus, Aetna, and it's a silver, like the same medication can be vastly different prices. And then with this whole convoluted PBM stuff going on in the background, like nobody knows where these prices are coming from, and there's no transparency. transparency. I had a patient this week who had previously been on a medication for his ADD, and he's a cash pay patient, and the symptoms are coming back and he'd like to go back on therapy. So I was like, okay, let's restart this. And I sent him a prescription to the same pharmacy, cash pay patient. So there's no insurance change here. And the medication is 3 times as expensive as it was before. Why? Like we're the only industry where the older things get, the more expensive they get. Everything else, like over time, the cost should go down. Your plasma TV or now flat screens are a lot cheaper. Like everything should really be more affordable now, but somehow it's just magically much more expensive. So I agree. I mean, we have to bring that transparency there, and direct primary care is the leader in being able to do that. I do think that doctors and patients initially kind of have this gut reaction when we see prices. We don't want to talk about them. Like having that conversation is hard, but by avoiding that conversation, this is how we got into the big mess that we're in, where nobody knows what things cost, or people are being ripped off left and right. So we have to bring some transparency back to the system.
I love what you're saying, and especially with the fact that the time that you get to spend with your patients, and then the focus that comes with that. So if you could let us know about working within this model. Now you have control over your schedule, and now you're able to spend some more time. Like, how has that time not only helped your patients, but how has that helped you? Because now, especially post-COVID, I remember before COVID, Dr. Dan and we were talking about just like more than half of America's doctors were burnt out, or a third, or some. It was a crazy number.
Over 60%. I think almost 65 at one point. It was high. Yeah.
I remember way before, like it was like a third or 50%. I was thinking, my God, so many physicians are burnt out, when it was like a third. How could you believe that? And then it went higher, like you said, 60%, 70%. Now we're reading about 80, 90% of American physicians are burnt out, exactly because of the reasons that you outlined earlier, because they feel this disconnect. They don't feel fulfilled anymore. So we talk about the time in the direct primary care being so helpful for the patients, but I'd love to hear about your day-to-day life, how that has allowed you to feel more fulfilled with practicing medicine again.
Oh my gosh, it's so many things. So what you said just brought up a lot of different ideas for me. One was, as I'm working on a new AHR system, and I had to set my schedule, and I was putting in how long I wanted for the appointments, and it felt so liberating, which felt so wonderful and just so ridiculous at the same time. I was like, I'm a doctor and I can do a 30-minute appointment if I want to. I just felt like I was breaking all the rules. I felt like such a rebel. And I was like, this is so sad that I'm so used to being dictated to how I can see my patients. I'm excited that I can set my schedule. So that was a very empowering moment. More time with my patients. My goodness. I think one of the biggest things I saw go away is I'm not a naturally anxious person. I'm not. And when I was in fee for service, I was anxious all the time, because it's always you against the clock and you're always going to lose, right? Where our jobs are 26 hours a day. We only got 24, plus we got to eat and sleep. So it was always me against the clock. So you get into that room, that patient's like, you know what, Dr. Cooke, I'm feeling pretty depressed. You know what, Dr. Cooke, I thought about taking my life next day. And you know that there are 12 people behind them. You can't reschedule them because it's going to be 4 months before they can get back on your schedule. So what happens? The palpitations start. Your hands are sweating. You're looking at the door. You're trying to do your best, but you're just put in that no-win situation all the time. And I just felt like I was always anxious of how do I get to the next patient? How do I get my documentation? Now I'm interrupted because there's an emergency. That cycle takes someone who, again, was not naturally anxious to being an anxious wreck. And you get home at the end of the day and you just wonder, why do I feel like I just went through a gauntlet? I feel like I was beaten down, just with how bad that day was. And that was business as usual. That was not just a bad day. That was every single day. You can't do that every day and be okay. So we talk about burnout. That's why, I can't go back to ever doing that. I tell people, if direct primary care doesn't work, which it will, I'm going to just have to be a yoga teacher, because I can't put myself back in that situation. I can't be on that time crunch when it comes to people's lives. It's just wrong. So losing that anxiety, I'm in the room and I'm with the patient and I'm present. And I can hear them, and I'm not worried about what's behind the door. And if somebody arrives, I know I still have plenty of time to get to them, and I don't worry. The other thing is, it has really helped a lot with the problem of access. I think this is something that we're discovering more about direct primary care, is now that I can do telehealth, my patients text message me, they send me portal messages. And if we think about the doctors who are in fee for service, they hate that. I hated it too, because portal messages meant uncompensated care, right? They can't get in, they send me a message, they want to know about stuff. And I'm like, oh my gosh, you want them to make an appointment. Why? because that's the only way we can convert it into something that's going to give us revenue. So we don't want to do all this uncompensated care. But in my model, they've prepaid for the month. So I'll deliver care however they want, right? Not everything needs an appointment. So I had a patient this morning. She's on a GLP medication for weight loss. We went up on the dose and now she's really nauseous and not feeling good, known side effect. She's like, Dr. Cooke, this dose is not working for me. I was like, you know what, darling, I got you. Let's drop the dose down, skip your next dose. Let's see how you feel. That was a text message. I didn't have to code it. I didn't have to do a modifier. I didn't have to do all that nonsense that drives us crazy in medicine. And she was taken care of without having to cross town, without having to sit in a waiting room and pay a copay. It's just clean. It's so clean. So when my patients come to the office, they really need me and we can really value that time. And if they don't need to come in, we can find other ways to manage their care. There are times where patients will text me or send me a message and, you really got to come in. I need to look at you. I need to lay hands. And they're more willing because now they've kind of been pre-screened by their doctor, not by a front desk person who's like, I triage them. Front desk is helpful, but, we've heard about, not to name names, but there's a large organization out there that's trying to do something similar to direct primary care that got in trouble because they had people who were not trained triaging people on the phone and there were some bad outcomes, right? But now my patients get to me, I'm like, no, this needs to be seen. I don't leave that in the hands of somebody at the front desk to handle it because I know my patients, I know it needs to come in. What's lovely is that, it just resolved the access issue. There's a whole day where I could be here and never have a patient come here and I've still served my patients because I've answered some text messages, I've done some portal messages, they know they have access to me, and that's the freedom of direct primary care. I don't need that full schedule. I don't need my office to be full of 20 patients a day in order to have a good day because the pay is actually the same. It's the same. So you're not as worried about the revenue. It's, I think, really the best way to look at value-based care.
It's obviously very rewarding. Hearing you speak, but if you had to, for somebody who's listening and hearing all these wonderful things, there had to have been some challenges that you had to overcome. So if you wouldn't mind sharing at least maybe one or two of the biggest challenges. It may have seemed as a challenge before, but now it's just nope. If you could share one or two of those challenges that you overcame.
There are definitely challenges, but what I always say is my worst day here doesn't even hold a candle to some of my best days in fee-for-service. Because I have challenges. We're doctors, right? We didn't go into this because we thought it was easy. We're not afraid of hard things. We're afraid of things that don't make sense and things that are just taxing for no reason. That's what we don't want to have in our lives. So there are definitely challenges. I will say if you are thinking about starting a direct primary care practice, one of the big challenges is the transition financially, right? I got a lot of runway by being able to have my loans forgiven. Luckily, even though I couldn't stand what I was doing in my fee-for-service job, it paid really well. And thank God I was able to put a lot of savings aside because I lived on my savings for the first year. I'm still not back to restoring the salary that I had. I'm getting close, but I'm not there yet. And that kind of feels icky. I'm 10 years out from practice. I'm supposed to be in the heyday of making all the money, and to take a step backwards financially is really hard. But another thing I say is I made less money last year than I've ever made as an adult. And it's been my happiest year yet because I feel like I'm finally living in alignment with my principles. I can be there for my family. I can be the best doctor and I can be the best wife and best mom I want to be. And so I know the money will come, but that hit is real, right? And so if you have, I had a lot of loans, but I got them forgiven. There's people with 2 or 3 times the amount of loan burden that I had that might have 3 children at home compared to my one that have other obligations that would make it very difficult to step away from a guaranteed, and I put that in parentheses, a guaranteed salary. We think these things are guaranteed until institutions start shutting down and people start getting termination notices. So I do think we have to understand that these positions that seem so stable, they're not as stable. As we just watched Steward Healthcare in Massachusetts collapse, to over 12,000 people out of job. But yes, the financial transition was very, very challenging and very difficult. The next thing that I say was a big challenge, this is one it's kind of a silly one that I laugh at, is when I got started, it was just me. I did hire a virtual assistant. So I have somebody that's on the phones that helps takes phone calls for me and schedule appointments. But I went from, having being a doctor and having this whole team to doing everything. So I did check in, I did check out, I did vital signs, and I started doing phlebotomy. And I tell you, I was terrified of phlebotomy. I was we've never really had to learn how to draw blood, especially our generation, right? We talk about the old old school docs were like, all over the hospital, all we had to do was draw blood. Like we were the phlebotomy team, but I really never had to do that. So I do draw blood in my office. And the reason I do that is because you can send your patient to a lab center, like a LabCorp or a Quest. There aren't that many in my community. Again, we've been decimated. Like all these services are gone. So it's not easy for me to send my patients out, and I need their blood work. So I had to learn how to draw blood. The first person I drew blood on was my husband. I'm thinking he's a man. He's very well hydrated. He works out, and his veins, I thought they'd be popping. They were horrible, and I could not get his blood. And I was like, okay, this is never going to work. I can't even draw blood. The whole thing is going to hell, right? Like I just thought it was all going to fail because I couldn't draw blood. And those first couple months were rough. Like I stuck people 3 and 4 times, and like you don't want to be the one that's causing them harm. But let me tell you what happened. My patients were so excited that I was doing something that held them at the forefront, that they were just so proud of me and so excited. Like, it's okay, Dr. Cooke, try my other arm.
Yeah.
Like they were rooting for me, they really wanted me to get it. And like nobody really complained about it because they knew that what I was doing was delivering the best care, and I was trying to do the best for them. So now I'm actually pretty darn good at drawing blood, but I've now hired some staff. I have a medical assistant that's working with me now, so I have to do less of that. But having to do all of that and like rehash skills that I just didn't have to use in my fee-for-service life was difficult. Again, mindset had to click in. I was like, Michelle, you are a whole doctor. You've delivered babies before. You've done all these complicated things. People have graduated from high school and gotten phlebotomy certificates. Like you can figure this out. But it was tough. When you're wearing that many hats, yes, you're only seeing 3 or 4 patients a day, but it can wear on you, right? It's one thing to do the doctor thinking, but when you have to do all those other steps, like it's a lot. So people are like, oh, these doctors only see like 3 or 4 patients a day. But if you're wearing more hats, like it can feel like a lot more. So that the change in pace was definitely something that it took me getting used to. But now that, the practice has grown, we have a little bit more in terms of finances. I'm hiring help because I don't want to do those things anymore. But now I have choice, right? You might be the doctor that says, no, I do want to keep drawing blood and I don't want to hire a medical assistant. I don't have to hire this whole team, but I have the choice of how I want to practice.
How do you see the rest of this decade, like the future of primary care? We've been in an evolving time. It's amazing. We're talking about the last 10 years, with fee-for-service. I never even heard of value-based care. I remember when I first, I remember even during COVID, my family, when they would see our podcasts and our shows, and my aunts and uncles would be like, what is this value-based care thing? Is this something to do with Walmart, like the Walmart brand? And I said, no, it's a different model of care. And what role do you think the direct primary care model will play with addressing the shortage of primary care doctors in the country?
Absolutely. So it's weird because I'm really of two minds. I am equally optimistic as I am pessimistic. I do think that direct primary care is going to save the system. Like, yes, we need to build out a whole better health ecosystem that has a lot more price transparency, but we know that the best health systems are built on the basis of a strong primary care foundation. Like, that's not for debate. Like, we know that. We've seen in every other country that has a great healthcare system, it's built on strong primary care. So I think direct primary care is going to be what gets us out of this mess. What I'm worried about is what's going to happen before we get there. I've already lost 2 hospitals in my community. I mentioned Stewart Healthcare in Boston that's collapsing. I'm originally from Boston. My parents live there. They're aging. And, I used to want them to come down to Atlanta to be closer. I'm like, you know what? Y'all need to stay in Boston. There's so much better healthcare out there. Like, I don't think Atlanta can care for you. I'm less sure of that now. Right? My mom is having a much harder time getting into her primary care doctor. I've told her to go direct, but she's holding out because she wants to believe in her insurance card still. But, harder to get to her doctor. Now, 2 hospitals that are critical to their community are closing. We're going to see, even before that happened, we heard that Mass General stopped taking primary care patients. Like, we're literally watching the system collapse. We're watching it collapse. So the pessimist side of me says that I know things are going to get a lot worse before they get better. Like, I think it unfortunately is going to have to break. It bothers me to my soul that here we are in an election year, and for whatever that means. And I feel like none of the conversations are about healthcare, and we are watching this institution crumble. So I think it's going to take people getting picked up by the ambulance or the ambulance not coming. They try to go to the hospital, but because they've all closed, like the nearest one is 40 miles away and they're overburdened. Like, we're just going to watch this whole thing collapse. And that hurts my soul every day. it hurts my soul every day. Now, in some ways, I feel like that may be what happens, that finally we can help get people into a new model. Like, I think when that happens, we're going to say, we spent all this money, have nothing to show for it. In fact, we have a more broken system than ever. Maybe we can take all this money we're spending and give it to our doctors and wipe out their student loans so they can get more, or they can start their direct primary care practices. Maybe we can funnel it back into primary care where it should have been. So I think the future, maybe 10 to 20 years out, is brighter, but I think these next 10 years are going to be a doozy. I'm very concerned.
Yeah, between just the physician burnout, what we're talking about, like most of American doctors are burnt out. Life expectancy for the first time ever is going in the wrong direction. That's just new. This is all just happening in the last couple of years. So I think you're right there. But I am very hopeful. I feel similar to you, especially with how you describe your work-life balance improving. What good are we to the patients if we don't take care of our doctors first? And if you've got a model where doctors can thrive and even doing things that maybe it's not things that we don't want to do, or, like with taking vitals or drawing blood and things like that. But if it's more fulfilling, that's okay. That is much, much better. Like you said, your worst day in direct primary care, there's no comparison.
Because, it's a little annoying to take a vital sign, but that's critical to patient care. You need to know what their vital signs are. What you don't need to know is this a level 3 versus a level 4? Or can I add them? Like, that's the stuff we dedicate so much mental energy to that has nothing to do with giving good care to a patient. So I felt like even though things were like, I don't want to clean the toilets, but my patients need a place to go to the bathroom and leave their samples, right? So everything I did felt like it was for good patient care. And I didn't burn out from that because it made sense of what I was doing. But the model that we have right now does not stand. The physician burnout is a huge threat just to the national security of our country, right? Like, if we don't have a place to get care, what happens if we have a disaster? And I'm just so concerned about that. But I do feel like direct primary care is a beacon. I'm glad to know there's something we can, like, there is like a life raft we can get off to. We need to make more of them. Like, I'm afraid we're not catching up fast enough with what the demand is going to be. We will get there. I think we have to. I think it's inevitable. We have no other choice.
Well, I think, and you've alluded to the fact that I've got more gray hair than other people. And actually, you talked about your tribe. One of my people I worked with as a medical student was a family medicine resident at the University of Virginia, who I think you probably know, George Brown, he was my supervising resident when I was a medical student. And,
oh my gosh.
Yes.
Small world.
So I've known George for a long time. He was your program director, correct?
He was my program director,
Right,
Dr. Brown. Yes, he's very, very dear to my heart. He's been a close friend and a big supporter of me.
But the issue, my dad was a mailman, my mom was a nurse, and they saved enough money to pay for me to go to medical school. So it was actually, medical school tuition was about double undergraduate tuition then, which, that was a stretch for them, but they still did it. And I finished residency without a huge debt in place, which allowed me to do a primary care practice. Now, I became part of the teaching practice at the University of Virginia, but still, that wouldn't have been a job I would have been able to take had I had $100,000 in debt at the time.
And $100 is generous. We're looking at 2, 3, 4. There's some students with $500,000 in student loans alone, like not their car, not their house.
But we have to figure out a way to fix the people going, because so many people choose not to go into primary care just because of the salary differential. But I think the main reason it's not the salary, it's being able to, how many more years do you have to work to pay off your student loans as a primary care doctor versus being an orthopedic surgeon? And just one other comment. So if you roll back to 2016 in the election cycle, there really was a lot of discussion about getting rid of Obamacare at the time. And at least that doesn't seem to be on the table now. Nobody's talking about getting rid of that. So I think we could make a lot more progress going forward. I was pretty scared as to what would have happened if all the pre-existing illnesses came back and all of that. So I'm hoping that nobody's going to try and get rid of that at this point.
And I think, I have a very different view about Obamacare now, because I think the heart was in the right position. But what I've learned on this journey is that the insurance model works when we let insurance be insurance. It protects you from catastrophic, non-ordinary events, right? The heart attack, the stroke, like the things that not everybody's going to experience. By rolling primary care into that, we put the ordinary into what's supposed to care for the extraordinary. And no wonder we're paying so much more for it, right? It's like the car insurance model is a simplified way to look at it. But if your car insurance paid for your gas and your brake changes and your oil change, like it would be astronomically expensive. So we really need to separate the basic parts of care, which is direct primary care, which is really very affordable and very, very simple. Like it doesn't have to be as complicated as we've made it by rolling it into an insurance-based model. So what we have is not health insurance. It's like prepaid care, and it's a monster. So I do feel like we have to kind of unroll that in some way. So I think the heart was in the right position, but we didn't choose the right model. Like we need to unhinge that and make insurance. So I tell my patients, even when they join my practice, that I want you to have insurance for those catastrophic events. Like I can't do your surgery. If you get hospitalized, you need some coverage for that. But everything else, we're just going to unbundle that. And you know what happens? They need the hospital less. All those tertiary care things, they need a lot less because they're finally getting good primary care. So this is the way that we unwind it. But yeah, just the way we're practicing and the way that we pay for care is so wrong. So that's, again, like getting that knowledge about how the finances work in this realm has helped me understand, like, okay, this is where the problems are, and we need to unbundle these things, and we're actually going to save a lot more money if we do it that way, and more lives.
Wow. Well, Dr. Cooke, what a great conversation. I mean, thank you so much for taking the time to come over here, answer our questions, and share your story. I mean, I'm hoping that if you're a student listening to this conversation and maybe learning about direct primary care for the first time, maybe it's not even the first time, maybe this is something that you've heard before, but hearing it this time, I hope that it'll inspire our listeners to consider direct primary care and really primary care, high quality primary care in general, as a fulfilling and impactful career choice.
Absolutely. That's definitely the message I want to send. And again, I'm just trying to tell all my colleagues, all of us coming up the ranks, that this is a viable option. So you talk about the community of direct primary care. We're all here to help each other. We are in a shortage of physicians, so there is no competition. I'm not going to not tell you my trade secrets, because even if there were 10 of me in town, we still can't meet the need of what this community needs. So we're all here to help each other.
Thank you so much, Dr. Cooke.
I really enjoyed it.
What are your thoughts on illuminating the path to DPC? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.